Hey there, and welcome to this explainer. Imagine just for a second that your body has this ultimate master thermostat. That's your endocrine system. It's totally driven by these incredibly delicate, invisible negative feedback loops. So today, we're going to explore exactly how our bodies maintain this miraculous balance. And honestly, more importantly, we'll look at what happens when those scales tip into dangerous territory. To get a handle on this, we're going to take a top-to-bottom anatomical journey. First up, we'll look at the master pituitary gland, then we'll drop down to the thyroid, check out the parathyroid glands right behind it, and finally, we'll finish up with the body's built-in stress centers, the adrenal glands.
All right, let's dive right in. Starting up in the brain with our master controller, the pituitary gland.
It's honestly wild to think that this tiny little gland, which is literally about the size of a pea, acts as a massive central relay station. The anterior and posterior lobes connect directly to the hypothalamus, taking input from your central nervous system to coordinate everything. The anterior lobe sends out these tropic hormones, things like TSH, ACTH, and growth hormone, which regulate your growth and metabolism. Meanwhile, the posterior pituitary is basically an extension of your nerve tracts. It stores and releases antidiuretic hormone, or ADH, to keep your fluid volume in check, along with oxytocin. Now, things get really interesting when we contrast hyper and hypo function here. There is a huge, sharp contrast. If you have a hypersecretory benign pituitary adenoma, just dumping excess growth hormone into the body, it leads to acromegaly. The pathophysiology here is literally an overgrowth of soft tissues and bones, especially in the face, hands, and feet. It also causes vision changes and hyperglycemia, basically because growth hormone actively antagonizes insulin. But on the flip side, hypopituitarism is a total systemic failure. You get a drop in one or more pituitary hormones, often because the tumor is actually destroying the gland. Depending on exactly which hormone is missing, patients can face severe weakness, completely unexpected weight gain, and ultimately life-threatening end organ failure. So as a nurse, how do you handle a pituitary tumor? Well, they're often treated with a hypopectomy, which is the surgical removal of the pituitary gland, usually done endoscopically, straight through the sphenoid sinus. If your patient just rolled out of this surgery, your primary nursing goals are hyper-focused on neurological monitoring. You absolutely have to elevate the head of the bed to drop that intracranial pressure. You're watching like a hawk for a cerebral spinal fluid leak. And to protect that surgical site, you've got to make sure the patient avoids any vigorous coughing, sneezing, or straining. Oh, and absolutely no brushing teeth for 10 days. They have to use oral rinses. Why? Because the pressure from brushing could literally rupture the surgical site. No way we want that.
Sticking with the posterior pituitary for a second, you really need to watch out for SIADH. This happens when there's a massive overproduction of ADH, very often caused by cancer. Because ADH increases the permeability of the renal distal tubules, the body just stubbornly holds onto water. It gets reabsorbed right back into the circulation. The result? It expands the extracellular fluid volume and absolutely crashes the patient's sodium levels, causing dilutional hyponatremia. Clinically, you're going to see low urine output, weight gain without any obvious edema, and some really dangerous neurological symptoms as that serum sodium just plummets.
Okay, let's move down to the neck and talk about the thyroid gland, basically the engine that drives your body's metabolic rate. This is a highly vascular, butterfly-shaped gland sitting right over the trachea. It actually needs iodine to synthesize its two main hormones, T3 and T4. And these hormones are absolutely crucial. They literally dictate the caloric requirements, the oxygen consumption, and the metabolic rate of pretty much every single tissue in your body.
So, the really critical point here is contrasting the two most common autoimmune disorders of the thyroid. Think of Graves' disease like a revved-up engine. Patients develop antibodies that actually stimulate the thyroid to just overproduce T3 and T4. It speeds everything up, causing weight loss and enlarged goiter, and that classic finding called exophthalmos, which is that bulging of the eyeballs because of fat and fluid building up in the orbital tissues. On the complete opposite end, Hashimoto's thyroiditis acts like a dying battery. Antibodies are actually destroying the thyroid tissue, which leads to primary hypothyroidism. The metabolism just grinds to a total crawl. We're talking extreme sluggishness, cold intolerance, unexpected weight gain, and a distinctly puffy face.
What's really fascinating is how our diagnostic labs perfectly capture these states through a negative feedback loop. In a normal, healthy system, high T4 turns off TSH. But in primary hypothyroidism, like what we just talked about with Hashimoto's, the thyroid is failing, so T4 is super low. The pituitary gland senses this and basically starts screaming for more thyroid hormone by pumping out massive amounts of thyroid-stimulating hormone. So the diagnostic hallmark for primary hypothyroidism is a really high TSH paired with a low T4. Make sense? Now in hyperthyroidism, like Graves' disease, the T4 is way too high. That suppresses the pituitary, so you end up with a low or even undetectable TSH. Now, if hyperthyroidism from Graves' disease spirals out of control, you're facing thyrotoxicosis. This is an acute hypermetabolic emergency. It drastically cranks up tissue sensitivity to sympathetic nervous system stimulation. Patients can present with severe tachycardia, hyperthermia, and just extreme agitation. This is a true critical care situation that needs immediate intervention. Right behind the thyroid, we find 4 tiny little watchdogs for your blood calcium levels, the parathyroid glands. These are tiny oval-shaped glands sitting right on the back of the thyroid. They release parathyroid hormone, or PTH, using a super simple negative feedback loop. When serum calcium levels in the blood drop, PTH gets released and acts like a rapid response rescue team. It jumps into action to pull calcium straight out of the bones, promotes calcium reabsorption in the kidneys, and even indirectly stimulates calcium absorption in your GI tract by activating vitamin D. The pathophysiology of parathyroid disorders gives us another stark contrast. In primary hyperparathyroidism, which is usually caused by a benign tumor, that excess PTH constantly robs the bones of their calcium. This leads directly to osteoporosis and pathologic fractures. And because all that extra calcium gets dumped into the blood and has to filter through the kidneys, these patients are at a massive risk for developing kidney stones. On the flip side, hypoparathyroidism is a lack of PTH. That leads to hypocalcemia, meaning a low blood calcium, which triggers some really severe neuromuscular irritability. When it comes to the nursing process here, you're highly focused on postoperative care. Because these parathyroid glands are embedded so closely to the thyroid, surgical removal of a goiter, like in a subtotal thyroidectomy or taking out a parathyroid tumor, can easily cause accidental damage to these little glands. This means you have to be on extremely high alert for an abrupt drop in serum calcium. You are constantly assessing for tetany. Watch closely for mild signs like tingling around the mouth and the hands, because that can rapidly progress to severe muscle spasms and life-threatening laryngospasms. Your most vital nursing implication, always, and I mean always, have IV calcium gluconate ready at the bedside for immediate emergency treatment. Finally, let's travel further down the body to the kidneys and look at our stress response centers, the adrenal glands. Sitting like little highly vascular caps right on top of each kidney, the adrenal glands are split into 2 main parts. Think of the inner medulla as your body's panic button. It produces catecholamines like epinephrine and norepinephrine for that immediate fight or flight response. Then you have the outer cortex, which produces your essential corticosteroids. This includes glucocorticoids like cortisol, which manages your glucose and inflammatory response, and mineralocorticoids like aldosterone, which keeps your fluid and sodium balance in check. Let's look at our final clinical contrast here. Cushing's syndrome is what happens when you have excess corticosteroids, specifically too much cortisol. These patients present with some striking physical changes: major fluid retention, fat redistribution that causes a classic moon face and truncal obesity, protein depletion that leads to super thin extremities, and really severe hyperglycemia. Conversely, Addison's disease is primary adrenal cortical insufficiency, basically a deficiency of all 3 classes of adrenal steroids. These patients suffer from progressive, intense weakness, severe weight loss, orthostatic hypotension, and a very distinct bronze hyperpigmentation of the skin. That bronzing actually happens because incredibly high levels of ACTH are trying, completely in vain, to stimulate a destroyed adrenal cortex. Because Addison's disease effectively destroys the body's ability to mount a normal physiologic stress response, these patients are in constant danger. If someone with Addison's faces a sudden stress, an infection, or even the abrupt withdrawal of corticosteroid therapy, they can spiral very quickly into an acute Addisonian crisis. This is a life-threatening emergency. It's caused by a sharp, sudden decrease in those hormones, which crashes the patient into severe hypotension, profound dehydration, and ultimately complete circulatory collapse. When your patient presents in an Addisonian crisis, your rapid clinical interventions literally mean the difference between life and death. Your immediate nursing priorities are completely focused on shock management. You have to administer high-dose hydrocortisone replacement immediately to give the body the cortisol it so desperately needs. You're going to implement aggressive fluid resuscitation to fix that severe hypotension, and you have to carefully monitor and replace electrolytes because these patients very often present with deadly hyponatremia and hyperkalemia. So, what does this all mean for you? Well, understanding these incredibly delicate scales of hyper and hypo function isn't just about memorizing some textbook facts or passing a nursing exam. It's really about anticipating life-threatening complications before they even happen. Whether you're carefully watching for a CSF leak after pituitary surgery, figuring out a TSH lab loop, getting IV calcium ready after a thyroidectomy, or spotting that bronze skin of an impending adrenal crisis, your knowledge of this system is literally your patient's safety net. As a clinician, how will you use the predictable rhythms of homeostasis to anticipate your patient's very next critical need? Thanks so much for joining me in this explainer of the endocrine system. Keep looking at the data, keep connecting the clinical signs, and never stop asking the right questions. See you next time.